أهلا بيكم. Today we're going to start the thorax series. So let's begin. We will begin the thorax by studying the chest wall. What does it include? Then we'll get deeper into the real thoracic cage, thoracic wall anatomy. For the pectoral region that in front of the anterior thoracic wall, we have a superficial compartment containing the skin, superficial fascia, and a gland for the breast mammary gland, and the deep compartment, which is the muscles beneath or behind or deep to the breast and the fascia. The breast is collection of mammary glands in the superficial fascia, in the fat and the connective tissue, and it's divided into lobules, and for the lobules to empty their production, they give rise to lactiferous ducts. There are around 15 to 20 lactiferous ducts opening in the nipple. This is the nipple here, and this is the glandular component, and this is fat. This is a cut section of the pectoralis major muscle, and this is the pectoralis minor muscle. Now the connective tissue surrounding the gland in the breast actually condensates in many areas in a certain pattern. You see those ligaments that are cut from the skin, see that? And how they are radial in arrangement. These are the suspensory ligaments of the breast, the suspensory ligaments of Cooper. And they're responsible for the pitting that appears during breast cancer. The breast cancer impairs the lymph drainage of the area, and the mass pulls on these suspensory ligaments that are attached to the skin, so they form dimples like the orange skin. They call it the orange skin in cancer breast. It's important for the structure of the breast. Now the whole breast is resting on the pectoralis major muscle, with of course the fascia covering the pectoralis, and the fascia which has the mammary gland in it. There is a potential space of loose connective tissue here on which the breast can glide, can move freely. It's not fixed to the underlying muscles. This is called the retromammary space. Why is it important? Well, you will encounter a common condition in which there are abscesses develop in the breasts of female. Now that you know that the arrangement of the ligament of Cooper is radial, so you should have a radial incision so as not to cut these ligaments parallel with these ligaments, and you make it deep on the back, because this is the most probable cause of the pus accumulation. And trust me, I saw a case, the breast wasn't enlarged at all, it was just little engorged and congested, but when we cut open in the level of the retromammary space plane, the quantity of pus that came out, you will be surprised. It's concealed and accumulated in this potential space. The base of the breast extends from the second rib to the sixth rib. Means takes 4 ribs from top to bottom. Okay. Remember that the nipple and area are supplied by the T4 dermatome. You know what's a dermatome? The dermatome is an area of skin supplied by a cutaneous branch, and this cutaneous branch came from a specific spinal cord segment. Okay, so T4 supplies the nipple and areola. The arterial supply for the breast comes from the surrounding arteries, especially from the axillary artery, that is the thoracoacromial, the lateral thoracic, which is a main artery and grows and gets tortuous even in pregnancy, the superior thoracic, the intercostals, they give branches to the breast, and the venous blood follow the arteries backwards to the axillary and to the internal thoracic, which gives the intercostals. The innervation, as I told you, the dermatomes on the chest, comes from the T segments, and the nipple is innervated by T4. The lymph drainage of the breast, this is the important thing, because if you are assessing a case of cancer breast, you must put in mind the draining lymph nodes that you should remove together with the cancer. Most of the lymph drainage to the axillary lymph nodes, most of them to the axillary lymph nodes, which open or drain into a main trunk called the subclavian trunk. Some of it to the posterior intercostal lymph nodes that present at the level of the heads and necks of the ribs. Some of it to the parasternal lymph nodes inside. Parasternal nodes are connected to the famous trunk called the bronchomediastinal trunk. Okay, so it drains mostly to axillary lymph nodes, to parasternal lymph nodes, and to subcostal lymph nodes at the back, near the heads and necks of the ribs. For men, there is no glandular structure, but there is remnants of ductules opening in the nipple. And by the way, men can get breast cancer, and this is the most aggressive form. It's the most aggressive type of breast cancer when it hits men. Okay. Now going deeper, you will find the muscle layer, which is the pectoralis major. This is the pectoralis major reflected, and underneath is the pectoralis minor. The major is big, and comes out from a clavicular head, medial part of the clavicle, and the sternal head from the front of the sternum and costal cartilages of the upper 6 ribs. It tapers laterally, going to the arm where it will get inserted, but please put in mind that the lower fibers inserted up and the upper fibers inserted down in the lateral lip of the bicipital groove, means that the muscle is twisted to make this smooth, fold, the anterior axillary fold. And the tendon of it is bilaminar, means it's 2 layers, because it's twisted on itself, and in the form of it's a broad tendon. You will see it when in situ inserting into the arm. Of course, the muscle by its position, it's an adduction, medial rotation, and flexor at the shoulder joint. We will study this muscle in details in the upper limb, but now that they are on the chest wall, so we must know a hint about them. It's supplied by a medial and lateral pectoral nerves. And deep to the muscle, you will find the pectoralis minor. This is the pectoralis minor. Observe that it arises from bone, not from cartilage, like the pectoralis major. It arises from the anterior surface of 3, 4, and 5 ribs, and tapers upwards, going to the coracoid process of the scapula, together with the subclavius, which is not present here. It comes from the first rib and inserts in the undersurface of the clavicle. Together they pull the shoulder forward and downward. Okay, it's like a protraction. It's deep to the pectoralis major, and the muscle is enclosed in fascia called the clavipectoral fascia. Now you all remember the deep investing layer. We stopped at the clavicle where the deep investing layer is attached. Some consider that the deep investing layer continues as the periosteum of the clavicle and then forms fascia. See this fascia here? This is called the clavipectoral fascia that splits to enclose the pectoralis minor, and after enclosing the pectoralis minor, inserts itself in the armpit, in the axilla, as the suspensory ligament of the axilla. So remember the intimate relation between the clavipectoral fascia and the pectoralis minor muscle. Okay, it's easy. So when you remove these, we will encounter the, as you can see here, the thoracic cage proper. Okay, the thoracic wall. Now we have a pillar in the center at the back, the vertebral column, and the ribs attaching to this pillar, to this column. And at the front, some of the ribs are joined by a bone called a sternum. So we will be talking about the sternum, about ribs, and about the thoracic vertebrae. The thoracic wall extends between the aperture, the upper aperture, bounded by the T1 and the first rib. You know all that. We studied this with the root of neck. And below by the lower aperture or inferior aperture, which is plugged by the diaphragm. But we are talking about bony prominences here from T12 and rib 12 to rib 11 to the costal margin to the anterior xiphoid process. This is the inferior aperture. Thoracic vertebrae are, of course, 12 in number, and they are classified as typical and atypical. Remember the cervical, we classified them as typical and atypical. Here, this is a picture of a couple of thoracic and a couple of lumbar vertebrae, thoracic lumbar vertebrae. Remember, the thorax has the heart, so the body is heart-shaped. The abdomen has the kidney, so the lumbar vertebra is kidney-shaped. You see that? Of course, you will notice the long process, slim process, tapering, going downwards. So when you are counting from the back, actually when you hit a spine, you are not opposite its own vertebra. No, you are a vertebra or two below. And this is very well evident in the middle of the thoracic cage, where the spines get longer and longer and longer. They may even reach to the third vertebra. It covers its own vertebra and two other vertebrae in the back. See, because it goes down. So put that in mind. If you counted T7, for example, you are not opposite T7 vertebra. You are opposite T9. Okay. We have articular processes, superior and inferior articular processes. The superior processes face posterior and almost directly posterior, and the lower ones face anterior to articulate with its fellow vertebra above or down. Okay, so these are the typical features of thoracic vertebra. What else? Actually, rather than its shape, it's the marks on the vertebra that helps in classification. You know, we have ribs attached. The rib attaches itself to the body of its own vertebra, transverse process of its own vertebra, and the vertebra, some of the body of the vertebra above. So the head of the rib has two facets on it. One for its own vertebra and one for the vertebra above. We call this demifacets. Demifacets, so they are present on the thoracic vertebra too. You expect to see demifacet superior and inferior, or costal facet, costal superior and inferior on the body of vertebra, because it will articulate with two ribs, right? Now, this is not the case in vertebra 1, because vertebra 1, T1, articulates with the complete 1 and half of 2, so it has 1.5 one complete facet and one demi-facet. Okay, the same is from T10 downwards, where the ribs articulate only in one place, the body of its own vertebra, so you have one complete facet, and this remarks them as non-typical or atypical thoracic vertebrae. Okay, these are the articulated vertebrae. See how it tapers downwards. See, when you are at this spine, for example, you are not opposite its own vertebra. You are two vertebra below. You see that? Now you got it. Okay, so this is about the thoracic vertebrae. The articulation with ribs. See, these are the heads of ribs. Each rib has a head, a neck, and a tubercle. The head articulates with the bodies of vertebrae, like you see here now. The tubercle articulates with the transverse process of its own vertebra. So you have three, actually, the rib and vertebra articulate in three sites: the transverse process, transverse costal process, and the facets on two vertebrae. This is called the transverse costal facet, by the way. It's oval in shape and articulates with the actually medial side of the tubercle of the rib. Okay, we talked about the differences in the articulations regarding rib 1 and rib 2, rib 1, and rib 10 through 12. The extra thing about the 11th and 12th ribs, that the vertebra do not have the transverse costal facet because there are no tubercles, so there are no articulation with the transverse process of the vertebra of T11 and T12. The T11 rib and T12 rib only articulate in a full facet with the body of its own vertebra, and that's it. Does not articulate laterally. Okay, observe the ligaments. Observe the ligaments and we will talk about this now. Now, for the ribs, we have 12 on each side, and only the upper 6 are attached directly to the sternum, so they are called true ribs. 7th, 8th, 9th, and 10th, they are articulating with each other. Of course, the 7th articulate with the sternum too, but with the xiphoid. It's not a completely to the body of sternum. They articulate with each rib articulate with the cartilage of the rib above, forming the costal margin. So these are called false ribs. Now 11 and 12, they are a special case because actually they do not connect to the sternum either directly or indirectly, and do not articulate with ribs above, so they are considered a special category, floating ribs. So we have true ribs, we have false ribs, and we have floating ribs. Every rib has a head that shows two facets for articulation with a crest in between. This crest is attached to a ligament that attaches the rib to the intervertebral disc. After the head, there's a neck and there's a tubercle. See, this is a tubercle. See the facet on the tubercle for articulation. It has a medial and lateral compartment. See that? And an angle at which, see the axis of the neck here changes abruptly at this angle. It's not the tubercle, it's the angle at which the shaft changes direction and goes forward. Now for all ribs, they have internal and external surfaces, but for rib 1 and 2, they have superior and inferior surfaces because they are flat. Okay, remember this, they are flat. See, 1 and 2 are flat, but the rest of the ribs have internal, means medial and lateral surfaces. You can also see that the first rib The tubercle is the angle, actually. The tubercle is the angle. It's not that the tubercle, then a distance, then the angle occurs. Okay? And for the fact that it's flat, together with rib 2 and rib 11 and 12, they are considered atypical ribs. See? Atypical rib number 1, rib number 2, 11, 12 for the criteria we discussed now. And may I remind you, for those who have practical exams, you may get a first rib and with questions about the impressions on it. You can easily identify the scalene tubercle for the scalene anterior. Remember the scalene anterior muscle. And we also remember that in front of the scalene anterior there was the subclavian vein, and behind it the subclavian artery, arching to come from or to going to the upper limb. If this is posterior, this is anterior. We're looking at the superior surface of the first rib. This is the scalene tubercle. So this is the groove for the subclavian artery. And this is the groove for the subclavian vein. The vein in front of the muscle, in front of the artery. Okay. By the way, the upper ribs, you know, the small ones, they move actually by rotating around their own axis, but the rest of the ribs, they move in an upward and downward movement. This is how you increase the thoracic cage from all directions. So that now that you have learned about the this is an important subject, by the way, the ribs and vertebrae, typical and atypical. Good amount of questions there. Okay, the last bone, the front bone, which is the sternum, it's composed of three parts: the manubrium, the body, and the xiphoid process. They are joined by cartilaginous symphysis joints. Symphysis means fibrocartilage in between the bones. Okay, so we have one at the manubrio-sternal junction, sterno-xiphoid junction. The xiphoid bone gets ossified with age. From beginning of the 40s, it starts to get hard, you know, calcified calcium deposition in the cartilage. The body of the sternum, you can see that it's like the vertebrae, as if they were in pieces and joined together. And this is the fact. They were in pieces. It was in pieces, each piece called sternebrae, like vertebrae, sternebrae. Okay? Now, on the manubrium, you have the suprasternal notch here, we talked about in the neck. And the first impression, and this is the confusing, trust me, you'll get confused in exam. The first groove lateral is not for the first rib, it's for the clavicle. Okay, so the first site here for articulation is the clavicle. Then this is the site for the first rib at the side. See that? Yeah, it has a complete facet. And this is the site for the second rib. Note that the second rib is attached to both the manubrium and the body with a ligament in between. Okay, the same like the principle of the ribs of the costal vertebral junctions. Okay, and for the fact that there is an angle between the manubrium and the body of sternum, angle, a prominent angle, you can feel it on your sternum at the front. This is called the angle of Lewis, or the manubrio-sternal junction, and it's an important clinical mark for because rib 1 cannot be palpated. It's hidden underneath the clavicle and with the structures at the root of the neck. So you can palpate the second one. The second one, you go down from the suprasternal notch until you feel the prominent ridge of the angle of Lewis. You go lateral. Now you are on the second costal cartilage. You put a finger there and then roll with the other fingers, the third, the fourth, the fifth, and it goes on. This is how you count the ribs, so it's of clinical importance. Okay, see at the side of the sternum, see the angle, it's very prominent. The body of the sternum also, before we leave it, have a demifacet here and demifacet down for the seventh rib, because the seventh rib articulates with the body of the sternum as well as the xiphoid in two places. That's easy, you will not get confused. Okay, about the costal vertebral joints, we talked about it, that it's between the head and the adjacent bodies of vertebra and demifacets. Okay, there's a crest at the head with the ligament attached to the intervertebral disc to make it stable. Okay, we talked about the articulation sites with the bodies of vertebra and with the transverse process of the of its own vertebra. Don't forget this. Rib number 6 articulates with T6 in superior demifacet and oval transverse costal facet and a demifacet on the lower part of the 5th, not the 7th. Don't confuse this. The rib articulates with its own vertebra at body and transverse process. Now, this costotransverse joint is stabilized by strong ligaments like the medial costotransverse ligament, lateral costotransverse ligaments. Actually, the lateral, like this one here, connects the non-articular part of the tubercle of the rib with the tip of the transverse process. The medial costotransverse between the neck and the transverse process, and the superior costotransverse ligament connects it with the is one of the ligaments that connected with the transverse process of the vertebra above it, okay, from the superior surface of the neck. So you have series of ligaments, medial and lateral and superior. And don't forget the radiate ligament. This ligament you can see here, that it's radial in shape. It has a slip to the upper vertebra, slip to its own vertebra, and to the intervertebral disc in between from the crest, okay, from the crest on the head. This is called the radiate ligament. If you don't want to count the interarticular ligament, okay, it's just for the upper body and lower body of the site of articulation. Okay, it allows, of course, I told you, the upper ribs for the rotation on its axis, and the lower ribs for displacement upwards and downwards. Okay. These are the sternocostal junctions. See how the second rib articulates with the sternum in two sides, one with manubrium and other with the body. You can see here the two different compartments with a ligament in between to the manubriosternal junction. You see the complete facets here. They are plain synovial joints, by the way, but the first one, remember that it holds the weight of the upper limb on it because the clavicle is superior to it. So it cannot be synovial plane. It's a fibrocartilaginous joint. The first sternocostal is fibrocartilaginous joint, but the rest of the sternocostal joints are synovial plane joints. Okay? And we talked about the site of the second and the site of the seventh. Okay, the joints between the body and the manubrium, I told you it's fibrocartilaginous symphysis, and we talked about the angle of Lewis. Now, at this level of the angle of Lewis, if you pass a plane horizontally to the back, it will pass through area between a lower border of T4 and the upper border of T5. Okay, so between T4 and T5. At this plane, many things happen, like the beginning and end of the arch of aorta. The arch begins at the continuation of the ascending aorta, begins at this level, T4 and T5, angle of Lewis, goes up and then comes back to the same level. So it's the beginning of end of arch of aorta. It's the plane through which the trachea bifurcates to right and left main bronchi. It marks the upper end of the pericardium, so it marks the lower end of the superior mediastinum. Now, above this level is the superior mediastinum. Below this level, in the midline, of course, in front of vertebrae, is the inferior mediastinum by this plane. And the plane is just superior to the pulmonary trunk. Of course, we will talk about this in details. Now, the intercostal spaces between the ribs, each rib, I forgot to show you that each rib has a costal groove. See that? This costal groove makes the inferior border of the rib, because this is an inferior view, sharp, while the upper border of the rib is rounded and smooth, because it's not carved in by a groove. This is called the costal groove. The costal groove contains the vessels and nerves of the space, the intercostal vessels and intercostal nerve. Okay? Like you see here, this is, and how they are arranged: the vein on top completely covered by the groove, then the artery, then below down is the nerve, as you can see here, the nerve, right? The nerve is not covered by the groove. It runs parallel to the edge of the groove, actually. So it's the most liable to injury if a trauma happened in the intercostal space, or a faulty technique in thoracostomy when you want to insert a tube. Make sure that you rub against the upper surface of the lower rib to avoid damaging the structures above your cannula. Okay, so this is it about the intercostal space. They are all separated from the pleura and lung by what's so-called the endothoracic fascia. It's loose connective tissue that you will find when dissecting the thorax. Okay. There's a special condition called the cervical rib, in which during development the transverse process of C7 grows as if it will become a rib. Okay, but the growth is it depends to what extent it grew, but eventually it attaches itself to the rib below, to the first rib, by a band, by a ligament. See, now some people live with it without any complications, but if it's big enough, it will press on the lower roots of the brachial plexus, T1 and C8, going to this way. Remember, we saw them forming the inferior cord of the brachial plexus, the inferior trunk of the brachial plexus. Okay, we said C8 and T1 combine to form the lower one, and they get compressed by this piece of bone, extra bone. So there are symptoms of pressure symptoms on a nerve, especially the lower ones in the roots of brachial plexus, pain along the arm and the forearm on the medial side, and may extend to the hand, or may even get weakness and numbness and even paralysis if the pressure is big. Okay, another clinical case regarding rib fractures. Now, fracture, you can fracture a rib, a single fracture. It will heal because it's enclosed in its own periosteum. It will heal, no problem with that. It even doesn't need casting, just immobilize the limb at the side of the fracture and give some analgesics for the pain accompany the breathing. Now, there are fractures in which the rib is fractured at multiple sites. So there's a piece of bone free here. Okay, this piece of bone shows a very characteristic sign. You know, when you take your breath, when you inhale, in inspiration, your chest expands. So you expect, of course, all the ribs to expand. But what happens here, that when you inhale, this piece or fragment of bone gets sucked in, and you can see it actually sucked in the thoracic cavity. And when exhaling with expiration, it goes back out. See, it's opposite the movement of the rest of the thoracic cage. This is called paradoxical breathing. Paradoxical breathing, in which this fragment of bone flips outwards and inwards with each inspiration expiration cycle. Now, if there was an external wound, so when it's sucked in, it will act like a valve, allow for air to get inside, and then when it's back to its place by expiration, it will close the area, so air will be trapped inside, and this is a dangerous situation. This is the danger of such type of fractures, that you get air in the thoracic cavity, pneumothorax, that will eventually pile up, compress the lung, and the lung will collapse. You will get a case of lung collapse. So you must assess the rib fractures very accurately, and observe for any separate fragments in your case, so to avoid this catastrophe of having pile up of air inside and the collapse of the lung. Okay, so this is it for the bony structure and framework of the thoracic cage, and some remarks on it and how the bones articulate. Next time we'll go deeper through the thorax, through the CS of thorax. Okay, thank you very much for watching and have a good day.